Well, thank you for that introduction. As you just said, I'm Kelly Kynaston, one of the Infectious Disease Fellows here at USF. And I'm going to talk to you today about adverse antibiotic events. So, first, of course, I have no disclosures, except to say that even though this is a required lecture, I did get to choose the topic. So, I picked this topic because I'm very cognizant of the fact that we're about to be, set free into the world, graduation time, and I do feel very strongly that infectious disease physicians should know everything there is to know about antibiotics inside and out. So that includes problems and issues that patients can experience from their administration. So in order to kind of prepare for this lecture, I was studying all kinds of information, and I tried to figure out how the best way to present it is. And finally I determined that, in order to organize my own thoughts, I made a whole bunch of tables. So they're my own work, they're not really intended to be comprehensive. Obviously there's a ton of reactions I'm leaving out, a ton of mechanisms even that I probably didn't even cover, but just sort of representative of what I wanted to say. So the slides may be a little bit busy, and I decided that was just fine. I was comfortable leaving busy slides there because it's really not the point of what I was trying to get at. That's just sort of the details of the information. The bottom line is to be cognizant for the potential of antibiotics to cause harm. Several of us were recently at the SHEA conference, and one of the SHEA lecturers had given us a lecture on how to give an effective presentation, and he said that people are only ever going to remember one thing that you tell them. So this is my one thing, is that antibiotics cause harm. I'll talk about mechanisms, I'll talk about recognizing things and management, but that's my sort of bottom line. So if my tables are a little bit anxiety-provoking, that you didn't memorize everything I put on the slide before I switch to the next one, that's actually kind of my desired effect. I want you to know that you don't know everything, about antibiotics. You can always look up the details later. But knowing that your medications can cause harm is the most important thing, so that you're doing right by your patient. So just to start out by defining a few terms, because they can be very confusing, an adverse drug event is differentiated from an adverse drug reaction. So an event encompasses all issues whatsoever that could ever go wrong with administration of a medication. A reaction are those problems that happen at therapeutic dosages. So that's kind of the first distinction to make. Side effects, like I said, therapeutic dosages are, issues that happen related to the pharmacological principles of the medication. Toxicity is when you move beyond beyond your intended therapeutic dose. And then hypersensitivity is just sort of an unpredictable reaction that's mediated somehow by the immune system. Similarly, drug allergies are specific immunologically mediated hypersensitivity reactions, so not just antibodies, T cells, but specific reactions. And then pharmacovigilance is the science and activities related to the detection, assessment, and understanding those basically studying adverse events. So what? Who cares? The reason that we should sort of care is 82% of Americans, this is sort of statistics that I had pulled from the CDC, not necessarily, hot off the presses 2016, but still relevant statistics. 82% of Americans take one medication, 29% take 5 or more. 700,000 emergency department visits are related to adverse effects, in addition to 120,000 hospitalizations. There's an estimated $3.5 billion spent annually because of problems with medications that are administered, and 40% of ambulatory costs are estimated to be preventable. Then from the Agency for Healthcare Research and Quality, which is more focused on hospitals in particular, 77,000 people are injured or die each year inside hospitals from adverse drug events, which costs any individual hospital up to $5.6 million a year, depending on their size. This estimate was not including sort of litigation and malpractice, so that's just sort of cost of health care. It's probably, the total cost is probably higher. And then, of course, the Joint Commission says that medication safety is one of their national patient safety goals. But as the ID consultants, I think we care way beyond just the regulatory reasons to care and way more beyond actual, money reasons. We care because this is a part of doing our job every single day to care for your patients. So I picked from over the course of fellowship over the last 2 years real actual consults or things that we've encountered, and that's hopefully going to help me illustrate some of the things I hope to discuss today. So the first is this reason for consult was an 87-year-old female who was allergic to all antibiotics except for Clinda. And she had the UTI. They gave her Clinda and it didn't respond. So please help make antibiotic recommendations. So yes, real consult a couple weeks ago. When I went and spoke to this patient, she had anaphylactic reaction to penicillins, and that basically had terrified her. She was intubated. She was adamantly refusing any and all penicillins. And then a few years later, she had been on Levaquin, and she had an altered mental status event, which, was not quite as scary maybe as intubation, but still not anything that she was interested in repeating. And so she started telling everybody that she was allergic to all antibiotics. On our history taking, I had found out that she had either never been administered or, didn't have problems and remembered being administered any of the other spectrums, none of the monobactams, none of the macrolides, none of, never been on Bactrim, so that we actually did have quite a few choices for her, just not according to what she was telling everybody and what was being documented. So that's my sort of first point to drive home, is to know, as the ID physician, you have to know what drugs are available. So like I said, I had quite a few tables here that I had made just to illustrate my point. Some of these drug reactions, like things that cause fevers, are very well known, either due to stimulating an allergic, an idiosyncratic reaction. Some drugs cause it by thermoregulation, but most of the antibiotics are either hypersensitivity or just idiopathic. So some drug reactions are very well known. Some, like maybe amantadine causing loss of hair, are lesser known. Not really a drug we use very often or anymore. Not necessarily a severe side effect, but, still there. Flagyl can cause angusia. I didn't even know angusia was a word. Spell check didn't know it either. So, some antibiotic reactions are extremely common. We know about this. We document our QTC on every patient at Moffitt Cancer Center. They're all on prophylactic Cipro and azoles together, which are QTC prolonging. Similarly, we document it on every VA patient we encounter, who also usually have multiple cardiac and psychotic comorbidities, which also prolong the QTC. So some reactions are just things that are very common. Some reactions are not nearly as common, much more rare. Usually if you see a patient that has developing infiltrates on their chest x-ray, you don't always think about eosinophilic pneumonias and maybe those ones that aren't responding to the addition of multiple other courses of antibiotics could have a different mechanism. So, my case number 2 is after I had received a page just notifying the infectious disease team that our 27-year-old IV drug abuser who had endocarditis had returned his room from downstairs just in time for his Rocephin infusion. After it started, he got flushed, dilated pupils, his blood pressure dropped, and this returned to normal within a couple of minutes. So in this instance, I remember talking with my attending and discussing the fact that this doesn't sound like anything Rocephin is known to have caused. Rocephin's half-life is much longer than the couple of minutes that he returned to normal, and we were suspecting maybe some line manipulation that the Rocephin then flushed a different agent into his system. But it still drives my point home that it's very important to understand the mechanism of antibiotics and kind of what you expect, side effects, how they could have happened. So, on this sort of set of nephro or kidney side effects, ATN versus AIN are very, very different mechanisms. They're going to present a little bit differently, and knowing the background behind how antibiotics will cause problems will certainly help you to differentiate whether or not that's the offending agent. Similarly, when you look at sort of electrolyte wasting antibiotics, the electrolyte wasting that happens due to AMPHO happens with a very, very different mechanism than foscarnet, which binds calcium. So, next case. I have a 54-year-old male who had glioblastoma multiforme who presented for a diverticulitis flare. First, he got a ciproflagyl combination and had a seizure because of it. That combo was changed to doxyflagyl, after which he developed a rash. Then it was changed to Zosyn, and his rash worsened. And then they got Marum, and the rash worsened. And then he got an ID consult. So my point behind this is how important it is to understand just sort of antibiotic pharmacokinetics, how long they'll stay in the system, whether or not they penetrate the blood-brain barrier, which antibiotic had likely caused which reaction. So pharmacokinetics is important. On this slide here, acyclovir causes very different adverse effects when it's administered IV than when it's administered via the oral route. Metronidazole has penetration into the pancreas, so pancreatitis for metronidazole due to direct toxicity is different from the hypothesized mechanism for pancreatitis due to pentamidine, which needs accumulation of the dose over time and likely really secondary side effects on glucose or like adenosine, maybe triglycerides. Let's see here. Drugs that cause bile duct toxicity then, maybe like Augmentin, definitely more reproducible injury than drugs like erythromycin if they're mediating the injury via eosinophils. So whether or not something's, dose dependent, dose independent will make a difference for whether or not you can continue to administer that antibiotic to the patient, multiple doses or in the future. So my case number 4 is ID following a patient, 63-year-old male who had a history of ESBL E. coli bacteremia. He got chemo and then, of course, developed neutropenic fever. Our recommended antibiotics were initiated, after which he developed stridor and hemodynamic liability. He needed intubation and had a brief arrest. So my point to illustrate on this one is to understand the severity of the antibiotic reactions, that some things could be very benign, but some things can be very severe, deadly reactions. This is a slide here from the National Cancer Institute. You know, oncologists sort of give poison for a living. And because of that, they have a sort of codified, formalized system here that's, let's see, it's called their Common Terminology Criteria for Adverse Effects. That's the CAE, that they rank the severity of the expected problem from their medications. And they do it for every system that there is. I just picked one, which happened to be blood dyscrasias. But basically they rank it from 1 to 5, with 5 being death, and really you're not going to give that, chemotherapy. But some of these things that are, 1 and on up to an expected risk-benefit ratio may be acceptable to do. So, let's see here. In terms of knowing severity, some reactions are relatively benign. I mean, tetracycline is incorporated into bone. You can have some ugly discolorations, but ugly isn't necessarily life-threatening. Bone marrow suppression with neutropenias, we're getting kind of worse on the spectrum there. Finally, when you're getting to things that cause neuromuscular blockade, the neuromuscular blockade effects of colistin, aminoglycosides, quinine certainly will paralyze the diaphragm, will cause respiratory arrest, and that can be quite severe. So the implication here is that, if you can give further doses, if the reaction is going to be reversible, irreversible, some of these things, like most of these encephalopathies, are reversible, wearing off when the drug's out of your system. And some are, like a lot of the paresthesias actually turn out to be irreversible. So my last case here is a 32-year-old penicillin allergic patient who was diagnosed with ocular syphilis. And so you need to also understand not only how to recognize adverse drug events, but also how to manage them. There's several different types of hypersensitivity reactions. Generally, when they're hypersensitivity, we tend to consider them pretty dangerous, even more so because they're so unpredictable. And as you can see from this slide here, there's actually quite a few from every category, or quite a few antibiotics in every category of hypersensitivity reactions. So definitely more research is needed into this field. So here's an example of some common appearing hypersensitivity reactions: DRESS, urticarias, vasculitis, Stevens-Johnson's. And you can see why they can be very difficult to diagnose. They appear very similar, but immunologically they're mediated very differently. So there's a lot of research sort of needed in the field of immunology to help look for or study these reactions. And in some areas they've made some tremendous successes. Linking abacavir to HLA-B5701 certainly has helped us to prevent the idiosyncratic abacavir hypersensitivity reaction. It would be nice to have that in other drugs as well. But as I was researching this, I came across this quote in particular from the allergy immunology literature that really struck me, and so I was going to read it to you. And basically, this leader in the field said that clinicians and researchers working in the field of drug hypersensitivity are very much aware that they're standing at the limit of repeating iatrogenesis. And I think that made an impression on me because, he's talking about how in order to study hypersensitivity, you're going to have to induce a life-threatening reaction in your patient. So it certainly made me appreciate what a challenge that is to do. But I also thought about how our own literature is kind of very paradoxical to this. So our literature in stewardship it's when I juxtapose it, it's almost very very contrast. So from the SHEA conference here, I actually reproduced this slide to give him credit directly from one of our SHEA conference lectures, and basically, on stewardship, I should say. So basically, he said that when treated for infections, patients with reported penicillin allergies receive broader spectrum, suboptimal, and even more toxic agents than patients without reported penicillin allergies, and that reported penicillin allergy has been associated with increasing antibiotic resistance, cost, and length of hospital stay and mortality. So, from our point of view, to not, to just, instead of inducing a hypersensitivity reaction, to not take that risk can actually also be very harmful to the patient. So, again, this one is reproduced from the SHEA conference, where the lecturer used this study here to illustrate that point that I was just talking about. And basically, this is the healthcare use and serious infection prevalence associated with penicillin allergies in hospitalized patients. And it was a 2014 retrospective study with 51,582 patients. And it showed that those with allergies received significantly more antibiotics, 23.4% more C. diff, more MRSA and VRE, and an increased hospital length of stay. So this, I think, is kind of dismissing true anaphylactic penicillin reactions, but what I found in the literature is, and even the allergy immunology literature, that only about 2 to 15% of patients labeled with penicillin allergy have a true penicillin allergy by the immunologic definition. So that's where we get a lot of this emphasis, and I think that's an important thing to understand. So, there was a recent EIN survey of infectious disease physicians, September 2015, with a lot of questions about antibiotic allergies. And number 9 here says, if the presence of an antibiotic allergy was excluded, how would this aid your practice? And there you can see there's a lot of different answers here. Better antibiotic selection, improved antibiotic appropriateness, safer administration of antibiotics, improved stewardship services. So the single most frequent response was the combination of better selection plus improved appropriateness plus safer administration and improved stewardship. So more of an all of the above there. And then number 10 here says, should antibiotic allergy testing be incorporated into antibiotic stewardship services? And you can see here 68% of physicians said yes, or infectious disease physicians said yes. I was a little surprised by this 23% who said that they were not sure. I can only speculate, but I was thinking maybe they don't know what all that entails.
I would say you want to separate allergy from stewardship. You would put it together or you would separate it out? That's what the question is asking. Some people say they should be separate things. They don't say don't do it. For me, the question should anybody be incorporated?
Right. Should it be a role of the stewardship
Should it be all
team?
One or not?
Yeah. So because of that, I sort of collected a couple of ideas on how good management of this situation should take place. This is actually from an allergy immunology textbook where I got a list of questions that the allergy specialist would ask a patient, and most of it's very, very similar to things that we would ask. Take a good list of, and some of it I think is more targeted toward the outpatient setting, but it can be easily tailored to the hospital setting as well. Basically, understand their entire list of medications, dosages, and how long they've been on any particular medication. Ask the patient, what drug do you think is the prime suspect, and why do you think that? Usually they have some sort of feeling, I was feeling fine until I got this drug, and then everything's gone downhill from there. You want to know when the reaction occurred, how long the reaction lasted, what was the sequence of events surrounding the reaction. Did it occur on first exposure? It does not have to do so. Some are delayed hypersensitivity reactions and can happen not immediately. Describe the reaction, was there swelling involved, was there itching, was there any other procedure that you had undergone at a similar time frame? Did you receive your flu shot that most hospitals give patients and that can cause some allergies? Did you have a contrast film and you got iodine, which is a very allergenic media? Is there any history of allergy to any other drug? Do you have any history of atopy? Have you had a family history of allergies? Do you have a concurrent viral illness, which can have an exanthem or have a predictable reaction when you're with penicillins that's not true anaphylaxis? How is your home environment? Are there mites in your home? Are there pets in your home? Are there other things you could be having a reaction to? So step number 1 is to take a really good history. If you're following a very formalized process, then step number 2 is to do skin testing. This is probably the part that infectious disease physicians do not order as frequently and don't have as easy access to, an immunology consult in the hospital setting. But it's considered the most reliable method for IgE-mediated reactions, meaning the intermediate type. It's not very sensitive for any antibiotic that's not a beta-lactam. So certainly beta-lactam is the best choice for this type of testing. The next step would be to do just a drug challenge, sometimes called provocation testing, which is really considered the gold standard. This should be done always in a supervised hospital environment, and you should get informed consent first of all, telling the patient the purpose of the test, the procedures that are involved, and the risks and benefits. Generally, this is performed by giving the patient a small dose of the drug and gradually increasing its dosage over 30-minute intervals if no reaction occurs. They're monitored about 1 to 2 hours after the procedure, and in the formal setting, any antihistamines, lisinopril, or beta blockers should be discontinued before, but I think that's probably only possible if you're admitting a patient specifically for this procedure. I think that realistically, in the hospital setting, when an infectious disease physician needs immediate use of an antibiotic, they probably also need some of their other home medications as well. And then sometimes, it's prudent also to be aware of having, maybe an EpiPen or antihistamines at the bedside as you're supervising your drug administration, just in case there is a life-threatening reaction. And then the last step, most important step, if you don't... Yeah, I'm sorry.
This is the desensitization protocol, correct?
Mm-hmm.
In other words.
Yeah. So, last step is, if you didn't document it, it never happens. I put an example of de-identified one of our patients up there where you can see that it says per infectious disease. Despite this penicillin allergy, Keflex was taken without any reaction on this admission. He's tolerated cefepime, meropenem, and other cephalosporins in the past. So just kind of put that picture up there to drive the point home. Hopefully I've convinced you ID physician needs to understand the antibiotics sort of inside and out. There's a couple of challenging scenarios that I've put in this lecture also. So first is what happens if you do identify a true penicillin allergy. You're not necessarily out of luck. So what I have here is a table of, it's not the photos themselves, but listed by name, all the cephalosporins grouped by their side chains. So this will help to guide you which side chains are very similar and are likely to cause that reaction, and which, like maybe ceftaz and the monobactams, are safe to administer to that patient. This is always something that can help guide your alternatives. Another sort of situation that we might encounter is what happens if your antibiotic infiltrates into the IV. In most situations, antibiotics are considered irritants rather than vesicants. And you can generally elevate the limb, put some cold compresses on, warm compresses, and it'll go away after a period of time. Because they are irritants, most of them also can cause like a phlebitis, and that's something that's very common. Either happens because of cytotoxicity or just the acidic or alkaline pH, so that's sort of agent specific, and you'd have to sort of look that up. But this certainly can happen. And then finally, I wanted to talk just a little bit on the fact that some adverse drug events may be synergistic. Here's a study that I had found highlighting the importance of like synergistic adverse reactions. Basically, it's a comparison of kidney injury between patients that received vancomycin and patients that received vanc and cefepime. I think it's important, despite these results, that either combination can still, have an additive effect. But in this particular study, 224 patients that were receiving antimicrobial combinations were evaluated, and the incidence of acute kidney injury was significantly higher in the piperacillin, tazobactam, and vanc group compared to the cefepime vanc group. Probably, if you were going to be a critic, you could say any patient you're picking broad spectrum empiric coverage for is probably some form of sepsis. They also had prerenal acute kidney injury, so that's probably a confounding variable. But I still think we have too much of a tendency to just sort of CYA. There's so many times that we're just afraid that we're missing something in our coverage. Add vancomycin, you got your gram-positives, your gram-negatives, your anaerobes, and that's not necessarily best practice. So, to conclude, I've emphasized the importance of recognizing adverse drug events. I've reviewed all their management strategies, and if you remember one thing from the lecture, the bottom line is that antibiotics are not always benign. And if you can remember that, you can stay true to your Hippocratic oath. Oh, there it goes. Questions?